Behind every doctor's career are personal sacrifices, long hours, delayed milestones, and sometimes tough choices about family. In today's episode, fertility specialist Dr. Becky Taylor shares what she's seeing on the front lines. More women and couples facing fertility challenges later in life, and a growing awareness around egg freezing, ovarian reserve testing, and fertility preservation.
If you're coming to me at 44 and you want to freeze your eggs, like that's not going to give you a good chance of success. Like the younger your eggs, the better quality, they're more likely to produce better grade embryos, they're more likely to result in live.
Here's what we'll cover. Why more doctors are having children later in life, what ovarian reserve testing and egg freezing actually involve, how age and conditions like endometriosis affect fertility, and what proactive steps women can take early to preserve their options. Because while you can't pause time, you can plan for it.
If we look at egg freezing, it's more available. There's more companies that offer it. If I'd known about it in my 20s, I'm lucky I've got kids, but I probably would have done it in my 20s if I'd sort of known about it or even thought about it. And I think what I'm seeing is it's a much more mainstream conversation now.
If you're thinking about it, get it done.
Now, without further ado, let's get into it.
Hi, everyone. Welcome to another episode of the Investing for Doctors podcast. Today, I am out of the recording studio and with Dr. Becky Taylor. Hi, Becky.
Nice to meet you. Nice to see you.
Yeah, awesome. So before we start, why don't you give an introduction about who you are and what you do?
So I'm Becky Taylor. I'm a gynecologist and work as a fertility specialist with Genea. I work at the moment at a glebe and a city in Kent Street. So I am English. I trained, was born over there and then went to medical school in Edinburgh and then did my intern residency over there and then ended up coming over to Australia for a year and met my partner and never left. I think I've been here about 13 years now and did all my specialty training and everything over here. So here's definitely home now. And just excited to be on the podcast today and spoken at some of your, one of your events before. And I love what you guys do in terms of sort of, giving doctors sort of, good life planning sort of opportunities. And I'm sort of, thanks for inviting me on to speak about, I guess, probably a bit of a different topic to perhaps what you're normally talking about.
Absolutely.
An important one. Yeah.
Beautiful. As a lot of our listeners, we have this concept of now, so not just investing in sort of finances, money, but also in yourself and family. And that's why we're here to talk about sort of family planning and fertility. As we, one of the things that I see as a doctor working in the emergency department, seeing interns, residents go through is that there is a huge demographic shift in doctors because we're now less likely to be undergrad. There's more postgrad programs. There's multiple barriers to getting, into medicine. And, we are also older as we get out. And then a lot of doctors, both male and female, have to consider when do they get married, when do they have kids and form their family. So, I hope this conversation will open up that topic for discussion amongst our viewers.
Yeah.
So I guess first of all, as a IVF specialist, what are the sort of trends that you are seeing over the years now in fertility? Are people coming to you older and older, or are people being more proactive about it? What's the general vibe these days?
Yeah, I mean, look, I think Australia-wide, we're seeing a trend towards women and men, but, women sort of having children later in life. And probably a lot of that is to do with, individuals who are sort of focused on careers, I guess more ability to choose, life's directions. I think also the option of fertility preservation options, which may choose for people to, delay childbearing. And also I think, seeing a degree of ambivalence in some of the sort of 20 something, I don't know what gen that is. I always get my Gen Zs and somewhere go wrong. But, an ambivalence about actually whether they do want to have children at all. I certainly feel like that. I mean, probably not in my office because I'm trying to help people have children. Sure. But, certainly, a lot of 20-year-olds, that I work with are like, I don't know if I actually do want to have children. And so, I think yes, there's trains to sort of later childbearing. But also the thing that I like that I'm seeing is there's a lot more talk about, fertility preservation options like egg freezing. Mm-hmm. And I'm certainly seeing a lot more people coming through my doors who are interested in doing that and interested in doing it at a younger age. So not thinking about coming to freeze their eggs necessarily at 37, 38, where you haven't had kids and they're not quite ready to, but actually like coming in 20s and thinking about freezing their eggs. So,
yeah.
I think there's a lot more. I think perhaps in the past was like, oh, you shouldn't talk about it. We should let, people do their careers. We shouldn't, whereas I think now everyone's going, okay, well, we know it's not a guarantee. And now we've got good options for fertility preservation. Let's think about doing those.
And do you think some of that is, we had this demographic of people that have gone through without that conversation, and then they're looking back and say, oh man, if I had my chance again, I would probably have thought about this earlier. Yeah. Is that like a bit of...
I think probably a little bit of that. I think probably social media has got something to play with it. No, I think like also if we look at egg freezing as like an option, it's, it's more available. There's more companies that offer it. There's, I think it's become more sort of known as an option. I mean, certainly when I was doing my training, I don't think like, and I was in training in obstetrics and gynecology. I never thought about like it's not something that even crossed my mind. Like, and I'm sure in my mind, I knew it was an option, but I didn't really it wasn't something like I contemplated doing. And I think now, I mean, if I'd known about it in my 20s, like I'm lucky I've got kids, but I probably would have done it in my 20s if I'd sort of known about it or even thought about it. And I think what I'm seeing is certainly like amongst, female doctors and health professionals and the wider, population, just a lot of, women talking to other women and saying, look, when you think about unfreezing my eggs, why don't you think about doing that, or speak to a specialist, or maybe go and check out what your ovarian reserve's like and things like that. So I think it's a much more mainstream conversation now.
And people are talking about it, so they're taking proactive steps.
Yeah.
And you mentioned to look at your ovarian reserve, for those that have never don't understand that process. What does that look like? And what say let's do a bit of role playing. Say I'm a 28-year-old female doctor that I'm just like, I've got a partner, but I'm just on the training program, and I'm thinking about, okay, what do I do here? When do I have my kids? What's the advice that you would give? Is it come and have do some blood tests, have a consult, and understand what the options are? And how does that look like?
I think that's really good questions. I mean, I guess if we're looking at like a basic kind of ovarian reserve assessment, which doesn't equate to like a full fertility assessment, but so as a woman, if you're looking at like, well, what's your ovarian reserve? There's two ways we can measure that. So there is the AMH, which is an anti-Mullerian hormone, which is a blood test, which measures a glycoprotein produced from the ovaries and is the kind of proxy measure of ovarian reserve. And then we also can do an antral follicle count, which is on a pelvic ultrasound, just like a sort of virtual sort of physical assessment of the number of follicles that are being recruited that month. So if you imagine like in a normal cycle, if you're ovulatory, like each month there's a crop of follicles, which is sort of jostling for position to become the dominant follicle that's released as a mature egg. The jostling, yeah. And the ones that aren't selected are kind of absorbed by the body and undergo atresia and disappear. And so the antral follicle count around day 5 to 10 is kind of looking at that cohort of follicles. Yeah. And so when it's very like low, that can suggest a low ovarian reserve. It's very high, can be suggestion of like polycystic ovarian syndrome. Also, younger patients, if you do a scan on someone who's 16 or 17, they'll probably have lots of follicles because they're younger. So those are a great kind of starting point for ovarian reserve. But I'm always sort of harping onto patients like, as I see a lot of patients who went and did the AMH, that antral follicle count is low, and they come in a panic to my office, and I say, look, this is not, it does not mean that like if you're not going to be able to like conceive, if we go back to like absolute basics, you need an egg, you need sperm, you need a way for the two of them to meet. So like if that's from natural conception, you need to have tubes that are open. If you're doing IVF, then you can make them meet in the lab. But ovarian reserve, I guess, to me, it is a measure of like, I guess an indication of time, right? Like if you have a very low ovarian reserve, that's only going to decline. So if you're in 20s and you've got a very low ovarian reserve, like time is not on your side, and you probably really want to think about some sort of fertility preservation or, if you're with somebody and want to, do you get on with it, right?
Yeah.
If you have a good ovarian reserve, equally that's like reassuring, but doesn't mean you're not going to have any problems falling pregnant. If somebody is wanting to do fertility preservation, like egg freezing, obviously the higher the ovarian reserve, it's, the more likely we are to get like a higher number of eggs.
Yeah.
So I guess to me, I look at it and I say to patients, it's a measure of like how much time you've got, although that's not like
there's no,
doesn't equate to like AMH of this, you've got like 2 years or 4 years or whatever. And then also, it's how I decide what dose of like FSH stimulation medication I'm going to give to somebody if they're doing a step like an IVF cycle or an egg freezing cycle. But there's so many other factors to kind of consider. Yeah. And one of the things often by the time someone makes it to my office, they've had an AMH and a natural follicle count. But sometimes I sort of say to people, colleagues or friends or whatever, I say, look, it can be a bit of a can of worms. Like if you're going to test and it's not what you want it to be, you got to have a plan. Like, are you prepared to do something about it? Which might be trying to conceive earlier than you had planned, or, doing some fertility preservation. Because if you don't want to act on it, then maybe sometimes I think, not knowing is better. Like if it's going to freak you out, you're like, I don't have the funds to do egg freezing, or I definitely I'm not in a point in my training to do, like try and fall pregnant at the moment, then sometimes I sort of say, well, maybe hold off until you are in a position, but equally you just don't know what you're going to find. So I think knowledge is power, but sometimes if it's not the knowledge you want, then
that's right.
What are you going to do, do about that? Yeah.
Now, back to that, jostling sort of concept, the way that I viewed it when I was learning about how that egg selection process works when you ovulate, it almost feels like the most is this idea that the most competent egg is the one that wins that fight, and almost there's a the anti-Müllerian hormone is sort of trying to suppress everyone, and it's the survival of the fittest, and the one that gets across will then say, haha, I'm the winner. Now all of you can go and die, essentially. Now, if we were to put that analogy in, would you say that, a younger egg is going to be more fitter than a older egg? Is there?
Yeah, absolutely. So definitely like the younger your eggs, the better, obviously there's going to be, within a group of 20, 25-year-olds, there's going to be variation in egg quality. But we certainly know that younger eggs are better quality. They're more likely to produce, better grade embryos and more likely to result in a live birth. So I always pick out once I've taken a history from individuals or couples, I always pull out this little graph, which is like your monthly chance of conception if you're trying naturally and there's no underlying fertility issues. So if you're under the age of 25, under the age of 30, it's only about 25% chance of falling pregnant each month. And everyone goes, what? Only 25%? That's really rubbish. And I'm like, yeah, we're not that great as a species at reproducing. I don't know what a rabbit's fecundity is, but I reckon it's like 95% plus or something, right?
Well, yeah, and there are multiple ones. Yeah. So I've done a lot of research in mice, and there's different strains of mice where they just have different litter sizes, and it's very interesting how the genetics of the mice actually will produce a different litter size. And I always wonder, is what sort of hormonal and sort of, genetic plays are at work. Why do humans tend to have one, whereas, twin pregnancies often run in families because there's a genetic component to it. Yeah. And, in the rodents, you can have a litter of 10. Yeah. Right. One of the basic biochemical sort of backgrounds going at it. And so that's sort of in my view, it almost feels like when you're born with, 100,000,000 eggs, you have, with each sort of, bout of the jostling.
I like that. Bout of jostling.
Yeah. So it's, like, the way I view it is that there's like a whole chain of eggs and it's sorted from good to bad quality. Yeah. And usually the better ones will start fighting first, and then they die off, and then the next bunch comes up, and next bunch.
Yeah, so certainly like 100%, like you see a decline in like egg quality, which we see as we don't have an objective measure of like the store-bought market defining egg quality. I mean, in the lab, the scientists make comments of like eggs have got, this marker or that marker, or they look a bit grainy, or, these sort of things. But we don't have a like, hey, this is a like great quality egg, or this is a terrible quality egg kind of as a marker, or it's certainly nothing that we can like do, to look at the eggs, other than how much like reserve sort of perspective, like in a person. But we see that play out, I guess, in your decline in your like monthly chance of conception. So we're talking about 25% monthly chance if there's no underlying issues when you're under 30, dropping to, by the time you're sort of 38, probably about 10 to 11% monthly chance of conception, to probably around sort of less than 5% once you're sort of 43 upwards. And the reason for that is that decline in egg quality. Now, age is probably the major factor that plays into egg quality, but there are other things too, like, we know endometriosis can have an impact on egg quality. And so, there are some patients who may have like poor embryology doing IVF that, we do a few cycles, the embryology sort of development is not great. And we sort of think about like, maybe do we do a laparoscopy, see if there's any endometriosis? And there are a cohort of patients that you excise the endometriosis from, and you sort of take the eggs out. You leave the eggs there, but you take the inflammatory environment away by removing the endometriosis, and then they do a cycle and do like way better from an embryology perspective. Other things like smoking, that can have an impact on egg quality. So environment, but age is the one that you can't,
It's just the non-modifiable.
It's non-modifiable, but I guess as individuals, people can do things about that, like fertility preservation, or, trying to conceive a little bit earlier.
And so you mentioned the risk factor, endometriosis is obviously one, and I guess polycystic ovary is also another sort of risk factor for infertility. Is that correct?
Yeah. So I guess like slightly, often with polycystic ovarian syndrome is the eggs are there. It's just that it's, I guess, a hormonal imbalance, which means that the eggs are not reliably released each month. And obviously if you're having like very long cycles, some months you're ovulating, some months you're not, it's very hard to track a cycle, time intercourse. And so often with polycystic ovarian syndrome, most of the time you can overcome it, potentially by sort of less invasive treatments like ovulation induction, where you take a tablet called letrozole to try and kind of help the ovaries sort of recruit a donor follicle and ovulate. And, if that doesn't work, then you can consider IVF. But the polycystic ovarian syndrome patients often, because you've got those eggs there, it's just a question of sort of getting them, creating the embryos, and then sort of putting them back in a favorable environment. The low ovarian reserve, endometriosis patients, when we do see in a sort of cohort of endometriosis patients where they seem to have sort of lower ovarian reserves than you would expect for their age, probably that may be due to surgery on like, ovarian cysts that have arisen from endometriosis. Sometimes just the inflammatory process seems to kind of be a negative environment for those eggs, and the quality and quantity declines sooner. But yeah, certainly like with endometriosis, we'll often see patients with lower ovarian reserves, and those are the patients that might not do quite as well from IVF. In terms of numbers, that doesn't mean like, you only need, one egg, one embryo, like one sperm, one embryo, and you could have a baby. But obviously I think that IVF often, it is a numbers game. And, if you've got more eggs to start with, there's more chances that you get like through the funneling of the sort of egg numbers down to so many eggs you get. Yeah.
And so, like, endometriosis is quite common these days, isn't it? Now, like, I always put a bit of like a evolutionary biologist hat on when I talk about sort of modern condition. It feels like, say, 50, 60 years ago, that wasn't really a thing, whether that was just a lack of diagnosis or people are just falling pregnant earlier. But the way that I look at it is that, why is something so common and so sort of anti evolution perspective? Because if that was such a major detriment to fertility, why have we got that trait built into us?
Yeah, I think that's a good question. I think evolution should try and do something about it, because it's like, it's a really horrific condition. I think probably, I mean, looking after patients, like from, I think the great thing is that there's more conversation about endometriosis, and, I can't remember what they quoted as it used to be like, I mean, was it like 8 to 10 years for diagnosis for a lot of patients, exactly. Which is just terrible, right? For me, I'm like, you've got pelvic pain. I'm like, I'm always thinking, you could have endometriosis, whereas it's not necessarily, what other doctors out there who aren't necessarily I'm a laparoscopic surgeon. I take out endometriosis every day. I think about endometriosis every day, whereas it's not like necessarily what a lot of other doctors might be thinking about. A lot of GPs might not have had a lot of education in it. I think the narrative is changing, and I think the government really, like in a great initiatives, like recognize that we have to put more money into funding this. And so like there's a new rebate that just came out a few months ago. There's a higher rebate for consultations for pelvic pain. I think there's going to be a rebate for endometriosis, specialized ultrasounds and things. I guess sort of going back to the, why has it not sort of disappeared if it's such an impact on fertility?
Oh yeah. Or why is it, in the days, say my grandparents' generation, they were able to have like 10 children, and it's not a problem. Yeah.
Well, I think because it's if it's untreated, it tends to be, progressive disease. So, you'll see a lot of patients that, they may have mild to like moderate disease, endometriosis in their sort of like teens, early 20s, but it hasn't caused any anatomical distortion. It hasn't caused cysts. They haven't had any surgeries yet. And so if you're trying to conceive and you've got endometriosis, yes, we know that mild to moderate endometriosis can impact on like fertility and natural conception rates. But if at that point you were trying to conceive and the endo wasn't that bad, you might be slightly less fertile than someone that didn't have it. But if the tubes are still open and the ovary reserve is okay, it's not too much of a problem, and you're full pregnant and you have a few kids, But then if you have a progressive disease that's like, trundling on through your 20s to your 30s, and then at 37, 38, you're like, okay, I want to have a baby now. That endometriosis might have changed the anatomy, in some of the sort of more destructive forms of it. It might have, caused tubal blockages. You might have had cysts on your ovaries. If you've had surgery for endometriosis, that can reduce the ovarian reserve. And so I guess the more time the endometriosis has had to like cause harm, the more chance it's going to impact on your fertility. And so that's probably why we see more problems,
Okay. Yeah. No, I get it. So it's had time to do damage, and that's why that's causing infertility. Yeah. So is one of the reasons why we never had so much is that people used to fall pregnant really early.
Yeah.
And I would assume when you're pregnant, the endometriosis doesn't.
Yeah, it's quiescent.
It's quiescent.
Yeah.
So, if you're having like, say, 10 children back 100 years ago, you have a lot more sort of non-ovulatory, I guess, time, as in time. You're pregnant.
I mean, look, potentially. I mean, I guess it's.
It is all hypothetical.
I mean, I guess the big thing is that there was probably a lot of women who went through horrific pain in the past who had normalized their period pain and their pelvic pain, and there wasn't a lot of awareness of endometriosis. Laparoscopic surgery wasn't as advanced as it is now, and so they had endometriosis, just wasn't diagnosed. But from a fertility perspective, I guess the longer you have endometriosis, potentially, if it's severe, the more likely it is to do damage, reduce your ovarian reserve, and then if you're not trying to have a baby till you're in your late 30s, it may cause more problems. Whereas if you had mild disease when you were 20 and you tried to have a baby, will sort of fall pregnant without too many issues. But then if it had progressed to severe disease by the time you're in your late 30s, then added to the fact that you're also a bit older and your air quality is poorer, it may have more of an impact.
Interesting. Yeah. So like I always think about, say, ADHD in it's a completely different field, right? It's like, ADHD is being diagnosed so common because our environment is different. Yeah. And but the fact that there is advantages and disadvantages you get from that. And, people with ADHD tend to be a lot more creative. They tend to think a lot faster. And, there's a lot of doctors with ADHD traits, for instance. And it sort of it has the potential to lead to sort of better sort of cognitive outcomes. Whereas if we looked at, endometriosis, it can't be just all bad. There must have been something that was good about it, from a evolutionary standpoint, for it to be so common in the human, in the human, genetics, right? I mean, but I mean, I think the current environment of whatever it is just causing it to.
But I guess, if you have your children when you're in your 20s, that's how it's kind of been able. It's something that as it caused problems from and it can cause problems from fertility to at any stage, but the longer it's there untreated, the more likely it's to cause problems. Okay. So I guess 50 years ago, if people were having kids, in their 20s, it gets passed on because, And look, it's really poorly understood. I mean, there's a lot of great work out there trying to sort of, fully understand, why do we know it's the presence of endometrial cells outside of the, uterus, but we're still not 100% certain, is it from reflux from the fallopian tubes during menstruation? Is it sort of, residual endometrial tissue from embryological development? I think there's still so much, it's been a very understudied, as a lot of things, unfortunately, in female sort of health, it's been relatively understudied. And so I think there's a huge amount of progress to be done in terms of, understanding the disease, treatments for the disease from pain perspective, but also fertility perspective.
Yeah. So then it sounds like if you have a risk factor for endometriosis and you have pelvic pain, it's probably worthwhile exploring is earlier. Later.
Yeah. Right. But it's interesting when you sort of mention back to the ADHD because, sometimes, we're diagnosing it more, which has benefits and also has sometimes, there can be downsides to to higher diagnosis.
Yeah, of course.
Is, sometimes then you find the endometriosis, are you more likely to have surgery? Surgery can sometimes reduce ovarian reserve. So it's always very nuanced. And I always sort of say to patients, look, the endometriosis we see at surgery is a kind of the visual end of a condition that we really don't fully understand. So, there's a lot of questions as to why does somebody has, a frozen pelvis with the worst endometriosis you've ever seen who didn't even have any pain and didn't even know they had endometriosis till they had difficulty conceiving. Yeah. Why do they have less pain than someone who's got a tiny spot of endometriosis that has crippling pain each month? And I think, again, that's where there's so much more study to be done. And I always say to patients, look, it's the lesions that we see at surgery, they are one part of a complex condition that's got a lot of things feeding into it, the pelvic pain pathways and sort of the nerve supply in the pelvis. We don't really fully understand how endometriosis affects those. So there's a lot of work to be done in that area. But I guess coming back to fertility perspective, yes, I think if you sort of, think you might have endometriosis, it's certainly worth, seeing GP, getting a ovarian reserve assessment done, maybe a deep infiltrating endometriosis scan done.
And what is that?
So a deep infiltrating endometriosis scan is it's an internal ultrasound, same as if, woman's having a, routine gynae scan, generally done by someone who's been specially trained to pick up, endometriotic lesions. So as our ultrasound machines have got better and people have done more research and training in it, they're now able to pick up kind of endometriosis which forms sort of deep infiltrating nodules. So, and, when you do a scan, you can kind of pick up suggestions of endometriosis, like the ovaries might be fixed, the womb might be fixed if it's quite severe disease, the rectum might be stuck to the back of the uterus in severe disease, and they're able to see these little nodules of endometriosis. Now, having a negative scan doesn't mean that you don't have endometriosis. You might have sort of quite diffuse superficial disease, but it's certainly, for me, I did them a lot for preoperative planning. Is there any bowel involvement with the endometriosis? Do I need the patient to see a colorectal surgeon before we do surgery?
Yeah.
And, we're very lucky in Australia. My understanding is in the UK, there's not as much access to that sort of type of specialized ultrasound. So most patients will have MRIs for endometriosis diagnosis.
Oh, okay.
Whereas here, we've kind of got access to really, certainly in Sydney, I could give you a list of places where you could go and get a deep endo scan done. So we're very lucky to have that, speaking to my British colleagues, to have that access to scans here. Yeah.
But the MRI so we can pick them up from MRI now.
Yeah, you can pick them up on MRI. I think we've just Australia, we've kind of gone the ultrasound route, and the UK has gone the MRI route. And so I'd probably argue that in Australia, we're better at reading the deep endo scans than we are the MRIs. The benefit of the deep endo scan as well is it's done by a doctor or an operative with specialist training. It's real time. So you can kind of see how things move. With the MRI, you can't see how things move. Whereas with the ultrasound, you can be like, does the uterus move at all, or is it totally fixed? Like, you get a lot more kind of real-time
move around or push on the belly.
Yeah, they just will like move the probe around. I mean, I don't do deep endo scans. Like they tell the guys that do them are amazing, and they're like, Becky, here's a nodule. I'm like, okay, I'll believe you. I'm like, it looks like 50 Shades of Grey to me, but like they're getting better and better, and like they're now starting to pick up subtle signs of superficial endometriosis as well, and so. I think in the past you say, look, the only way you can diagnose it is on the laparoscopy, whereas now it's actually, we can certainly diagnose a lot of it on a deep endo scan, but as I said, a negative scan doesn't mean there's no endo.
Yeah. One of the people that I work with, they're looking at it from a, genetics perspective, and, obviously a lot of this is hereditary in a way. How hereditary is endometriosis from yours?
Oh, look, I'm probably not the best person to ask. I know there's a group in Sydney that do a lot of research, like Jason Abbott's group doing a lot of research into endometriosis, and certainly like I see a lot of endometriosis patients that are struggling with fertility or wanting to have surgery, and when you take a family history, they're like, my mum had it, my sister had it, often runs in families, but I guess there's not, to date, we've not found like a, dominant gene or something that's like, it's like not inherited in some sort of autosomal dominant fashion. But certainly it seems to be like strong family kind of traits.
I mean, in my, like, I've seen some of this stuff, and again, it's one of those polygenetic risk kind of things where you have a gene, this contributes, and it's like maybe 10 different things, and it hits the threshold. I mean, there's a lot of conditions these days that we see that are not sort of the monogenetic, highly penetrant disease like classical genetics.
Yeah, and that's the same for like polycystic ovarian syndrome. Again, like tends to run like there's a familial aspect to it, but
exactly.
There's not a sort of definitive gene that's like, yep, you have this, you definitely, and
the other thing is that I think in Australia, because we're so multicultural, like the polycystic ovary and the endometriosis, they all seem to be very, different, because like, I'm Chinese, and there's actually a lot of Chinese women that are skinny fit, but they have like tons of polycystic, cysts on their ovary, and, they don't really have the hirsutism or the insulin resistance. Like, do you see that, or is that something that I'm just seeing?
No, like I definitely think, I think at the moment we've got like various endometriosis classifications in terms of like, at surgery stage 1 to stage 4, but I certainly think that there's and I think they're working on a number of biomarkers. Like I think in time there will be like classifications of almost like totally like separate forms of endometriosis that, there's certainly some forms of endometriosis seem to respond better to surgery, like the sort of nodular infiltrating ones where you can imagine you could see that and be like, that would be painful. Like that ovary is totally stuck. And then other times you're like, there's sort of a diffuse superficial disease, there's no nodules, and you're like, this is like a completely different looking disease to what Liz or any other patient. So I think things will move and things will change, and there'll probably be like, separate classifications of endometriosis, and probably then sort of from that will come separate sort of treatment suggestions for different types.
Yeah, awesome. I mean, that's all very fascinating, because like, some of the listeners might know that I sort of dabble in the science side of things, and it's good to hear that's what's happening on the ground, and hopefully one day we'll have more answers there. Doing all of those things. So I mean, I think we've spoken about fertility and reserve, but like, for those that don't actually understand the IVF process, do you mind sort of just sharing with the audience what that is like? Because I think there is that ovarian stimulation bit, there is the actual IVF bit, and often there's a lot of mixture of concepts.
Yeah, definitely.
Yeah.
So I guess the thing I would say, like if you're doing, egg freezing or you're doing IVF, like the initial stimulating like part for the female is the same. And then things divert once the eggs are retrieved. If you're doing egg freezing, the scientists will freeze the eggs. And if you're doing IVF, they'll fertilize the eggs. And we'll talk a little bit more about embryo development in a bit. But essentially kind of we go back to that jostling for position each month. So, as I said, normally there's dominant follicles selected from a cohort of follicles and will become the dominant one, which is ovulated. And what we're trying to do with the IVF process is say, okay, hey, you guys didn't, instead of allowing a front runner to emerge, you're trying to get all of those follicles in that arrow to kind of come on the journey and grow to a sort of size that we're kind of expecting to see a mature egg from. And the way that we do that is by stimulating the ovaries with a hormone called FSH, or follicle stimulating hormone, which is a hormone that's naturally released by the body, but we're kind of giving it in super physiological doses. And the aim of that is to kind of then grow a crop of follicles. So typically what patients will do, there's various ways to start a cycle, but, say we're going to just go for a straightforward natural start. Patient gets their period, they have bloods done, when the period comes, to check the hormones are sort of flat as they should be at the start of a cycle. And then that day or the next day, they'll start a FSH injection daily. There's a few different types of cycles we do, but essentially over the course then of on average around sort of 8 to 14 days, we will monitor the progress with a series of bloods and ultrasounds. So, again, different units will monitor at different times. Typically, I will do a blood test on day 4, check that the estrogen is starting to rise. One of the most common cycles you'll do is what we call an antagonist cycle. So as that estrogen rises, there's hopefully lots of follicles developing. They can kind of cause each other to prematurely have an LH surge. They kind of get each other all going essentially. And then you could sort of end up ovulating a whole lot of immature eggs, which would not be, before they're ready, before you got the chance to pick them up, which you don't want to happen. So then you normally add in a second injection from around day 5, which is called an antagonist. And what that does is it sort of stops your natural LH from surging and means that you kind of keep them in check, for want of a better description, so you can grow those follicles without them escaping before you get your hands on them. You do the egg retrieval.
Premature.
Yeah. And so then, normally I'll do another blood test on around day 8 and also an ultrasound. And hopefully by that point, we're sort of starting to see some follicles growing. Everyone's a bit different. Some people will go off like a rocket. Some people are a bit more slow. It's no right or wrong. It's just everyone's different how their ovaries respond. But essentially we'll start to see some follicular sort of recruitment. And then, some people are pretty ready to go around day 8, day 9. They've got a leading crop of follicles or in the sort of 18 to 22 millimeters in size. Mm-hmm. And then we're sort of ready to trigger them to do the egg retrieval. And some patients, may have a series of more blood tests and scans as we try and grow those leading follicles to a bigger size. Yeah. So we're sort of aiming to kind of have the leading follicles being around the sort of 18 to 22 millimeter mark. But you kind of will hopefully get a mature egg out of, hopefully about the 16 millimeter size, of 50. It's, you got to remember, these ultrasounds is a millimeter on an ultrasound is not very much, right? So, that's right. Sometimes when you do the egg retrieval, you'll get more than you're expecting, and sometimes you get less. But essentially, once you've kind of I think we've got a good crop of follicles, then you're basically ready, prepare for the egg retrieval. And the way we typically sort of prepare for that is we give a trigger injection. It's typically a medication called Obadrol, which contains HCG. And there are different types of triggers we can use, and you give that on average around 36 hours before the egg retrieval. And then the patient will come into the fertility unit to the day surgery, and depending on the specialist, that might be done just with some fentanyl, or I generally do most of the sedation with an anaesthetist, and we'll do a transvaginal ultrasound, and it's got a little needle that comes out the end of it, and that goes into the follicles, drains the fluid from the follicles, goes through the little tubing into a test tube, and then we'll have the scientists in the room with us, and they basically look through the fluid under the microscope and find the eggs. And then if we're doing egg freezing, they'll take them to the lab, they sort of strip the cells around them and then assess for maturity. So we like to freeze mature M2 eggs if we're doing egg freezing, and then they'll just freeze them if that's all we're doing for egg freezing. And then for the IVF patients, they'll fertilize those eggs. So that might be typically through a process through the IVF process, where they just put the sperm and the eggs in a dish together and let the best sperm win for each egg. Yeah. If there's sperm motility or quality issues, then you're doing it for genetic testing for inherited conditions, then you might do ICSI, where you actually inject the scientists inject the head of the sperm into the egg. So yeah, that's sort of all dependent on like individuals.
And the male factor.
Yeah.
So the
And so like then if you're doing IVF, then essentially the scientists will, I mean, and all labs are different, but essentially where I work at Genea, like they'll do a fertilization check the next day. So they'll update the patients and let you know, like, you know, how many fertilized. And then our preference at Genea is to grow the embryos at the day 5, day 6 stage. So you kind of get an update on day 3 and then day 5. If we're doing like an embryo, like if we're trying to get pregnant, we're not doing preservation, might put an embryo back on day 5. And the way we do that is we'd come back into day surgery unit, put a speculum in, little catheter goes through the neck of the womb, and then we place the embryo at the top of the womb under ultrasound guidance. So that's much less invasive than the like the egg retrieval, where we're sort of putting a needle into the pelvis. Yeah. So like normally, they're pretty uncommon. You have to do like any sort of sedation for an embryo transfer. I mean, look, there are some patients find extremely difficult to have internal examinations where that might be required, but that's pretty uncommon, but we can kind of accommodate for whatever needs to be done. And then any embryos which aren't suitable for like that haven't been transferred and are suitable for freezing, they will freeze on either day 5, day 6 stage. There is the option of doing like genetic testing for chromosomal abnormalities. And so a lot of patients sort of opt into doing that. Obviously we can't test, well, at the moment, we can't put an embryo back fresh and like test what we could test it because the result takes around 2 to 3 weeks to come back. I'm sure in time that'll change and I'll be able to be like, you know, whip off a little bit of a biopsy and then like put it in the machine and have a result 5 minutes later, but I don't think we're quite there yet.
No, we're not there from that.
But one of the big things I always sort of like talked about my fertility preservation patients or the IVF patients is like a big, you know, I think sometimes there's this conception that like an egg is an embryo and it's really not. There's a huge like funneling and attrition from like eggs to embryos. So I normally say first do the cell pile system. So this is like a real like, you know, sort of test of the best selection. But so for every like 10 fresh eggs, you know, this isn't a good cycle, like an average cycle. And like obviously there are people that do better, there are people that do worse. For every 10 fresh eggs you collect, you probably expect about 8 will fertilize. You'll get about 6 to the day 3 stage, and then you'll probably get about 2 to 3 embryos to what we call the blastocyst stage on day 5. If you then do genetic testing, then you might further reduce the number of embryos that are suitable to use. So like say at under 30, probably 25% of embryos you make will be chromosomally abnormal. By the time you get to like 43 plus, it's like more than 90% will be chromosomally abnormal.
Yeah.
And so, you know, that can reduce. Then if you decided to do testing, that can reduce the number of embryos that are then suitable to actually put back. So, you know, you're kind of going from 10 eggs to like 2 to 3 embryos in a good cycle. Like, of course, I've said that people buck the trend and get, you know, 6 embryos to use or like, you know, more than that. And obviously the more eggs you get, I guess, as I said, it is a bit of a numbers situation. Like the more you get, hopefully the more chance that you get embryos. But, you know, there are some patients that just have really, you know, like as a couple, they just have really poor embryology. And, you know, that can be related to, you know, sperm quality, underlying health issues, endometriosis, unexplained factors. Like there's still so much we don't understand about your fertility. Yeah. But I'm always kind of quite like sort of mindful of like, I guess, harping that home, particularly my patients are doing egg freezing. You know, we don't, interestingly, when you kind of look at the numbers, like worldwide, probably only about 10% of patients have frozen their eggs actually gone back to use them to date.
Really?
And that's probably because it's not been like mainstream for a while. So a lot of those patients just haven't got around to using them yet, or like they felt pregnant naturally, or they decided they didn't want kids. So a lot of the data we have in terms of, well, like what's egg freezing, like what are the success rates, actually come from kind of donor eggs. So using, you know, young donors who donated eggs to couples that are suffering from infertility. Yeah. And that's probably like, you know, if you're going to pick the best eggs ever, you'd be like the, you know, like clinic recruited egg donors. They're young, like ovarian reserves. Yeah. And so that probably doesn't, you know, completely extrapolate to the patients that walk through my door, which is everyone. You've got people in my 20s, people like in their 20s, people in their 40s, you know. I think we will get more information in that sphere, like over the coming years as people start to go back to use their eggs. Yes. But I always sort of say, like from a fertility preservation perspective, like it's not a guarantee, like it's an insurance policy. Yeah. But, you know, when you're freezing eggs, you're freezing them at the earliest point in the journey. Like you don't know how they're going to act when you put them with some sperm and try and make an embryo.
Yeah.
Like you might be someone who makes beautiful embryos, but you might also be somebody who has really poor embryology.
Yeah.
And so, if you froze your eggs at 30, but then you don't go back to using them until you're 44, then your chances then, if those eggs don't give you a baby, of then doing IVF, like, yes, you can do an IVF cycle at 44, but your chances are going to be low. Yeah. And the other thing I want to talk about egg freezing is that, when we freeze the eggs, they're just a single cells. They're not quite as robust as when we freeze a blastocyst, which is made up of hundreds of cells by no point. So when you warm an egg up to use it and fertilize it, probably about 80%, like on average, kind of industry standards, probably about 80 to 85% of eggs will survive the warming process. So say you had 10 eggs frozen, you probably had 8 when you're actually ready to go once they're warmed up. And then, like for like, they seem to work sort of, comparably to like fresh eggs, but you're kind of looking at, then, 6, 8 for you, 6 fertilized, maybe 1 or 2 embryos from, you had 10 eggs to start with, you might have 1 or 2 embryos for you.
So it sounds like for every 10 eggs, you're going to get safely, that's a ballpark, 1 or 2.
Yeah. So fresh cycle, doing IVF, probably, good cycle, average cycle, 2 to 3 embryos to use before testing. Egg freezing, you're probably looking like 1 to 2.
Wow.
Yeah. So it's a big attrition rate. So then people always like, well, how many eggs should I freeze? I'm like, well, that's a big question. I mean, there was a recent study which looked at the mean number of eggs you needed to get 3 euploid chromosomally normal embryos. And I think, might be quoting slightly wrong, but I think if you were under 35, it was 15. Yeah. If you were 35 to 40, it was 30. And if you're over 40, it was you needed it was huge.
And it's already hard to get eggs out of those women at that age. Yeah.
And so, that's when it's well, it's hard to say how, because, how many do you need? Well, the more the merrier, but equally, if you're only getting 5 bottles of D, it's not cheap, it's expensive. You've got to put your body through multiple cycles. So, I sort of anecdotally say, well, look, 20 is a good, number to aim for. But, for some patients, it's a slam dunk, 1 cycle, 20 eggs. Thanks, Becky. I'm out of here. You're doing great. That was super fine. Yeah. And other patients might only get 1 or, with a low ovarian reserve, they might only get 1 or 2 eggs a go. And therefore, for them to get to 20 is highly unrealistic,
Yeah.
I mean, I'm not going to say there's never been anyone out there that's not done that, but it's a lot of time and stress and.
I'm just thinking of this dystopian future where as both men and women, as they get to adulthood, you just get to get that eggs harvested and stored away. That's almost I'm seeing this dystopian future. Or maybe that's the utilitarian future.
I've shifted my sort of thoughts about, I think as more data's coming out, I used to say, oh, early 30s, well, if you're on the fence about it, you've got a good ovarian reserve, you could do it, but you could equally wait a few years, see what happens. And now I'm no, if you're thinking about it, do it. Cause your eggs and the one thing I can guarantee you is your 20-year-old eggs are going to be better than your 30-year-old eggs, are going to be better than your 40-year-old eggs.
Oh, absolutely.
And I don't need any markers or anything of that. The egg quality only goes when you cook. Obviously, you can remove endometriosis, you can stop smoking, you can do all those things, but really it's only on a sort of downwards trajectory. And so if you're thinking about it, do it, sooner rather than later. But you've also got to weigh up the chance, if you do it when you're 20, and then you meet someone you want to have a baby when you're 28, you might have spent a whole lot of money doing egg freezing and you never use them. But, I guess that's for, each individual to.
Yeah. Oh, that's our major consideration.
Yes, exactly. And it's not cheap, it's, and it's tough. It's, I will say to a lot of my egg freezing patients, I'm that wasn't as bad as I thought it would be. They come in and they do their tracking before they go to work. I mean, obviously doctors is can be hard because you're on night shifts and
so
that's a try and get in, trying to get anywhere at 7 and then get to wherever you work and you're probably in a different hospital every, few months, can be tricky. But, a lot of, I think it's, particularly if we're doing the egg freezing, you're only really looking at about 2 weeks that you're sort of committing to it. And then because we're not putting an embryo back, you can kind of, still you might be a little bit sore, kind of, still a bit bloated and stuff for a week afterwards. But most people have the day of the egg retrieval off and the day off afterwards. And then most of them are kind of, don't go run a marathon the next day, but most people are able to go back to work and things like that. Yeah.
Okay. So I think to conclude this first part, it sounds like if you're thinking about it, get it done.
Yeah. Yeah. Oh, then have a conversation, right? That's what I say. Go see someone and, I'm very happy to sort of say, look, like these are chances, like, I think your ovarian reserve is good. I don't think you need to be worried, but like, yes, I can tell your egg freezing now is going to be better than if I do it in 10 years' time. And also say, look, if you're coming to me at 44 and you want to freeze your eggs, like that's not going to give you a good chance of success. Like, I don't like, obviously it's up to you, but I don't strongly recommend that at all because the chances of success would be so low. But, I think go and have a conversation with a fertility specialist, think about like, whether you want to do further investigations. There are other things you can think about, like doing genetic carrier screening and things, because sometimes you start these investigations and you find like, and I've really largely spoken about like the female side of things, but, equally, yeah.
We're talking about the male.
Okay, well, we'll stop there. Yeah. But equally, there's two parts to every story.
There's two parts to every story. Yeah, absolutely.
Yeah.
Thank you so much, Becky. And we'll catch up with the next episode.
Sounds good.
Beautiful.
This podcast is for educational and entertainment purposes only. The information and opinions shared are not intended as personal financial advice. The content presented should not be relied upon for making financial investment or other decisions. Listeners are strongly encouraged to seek the advice of qualified financial or legal professionals before making any financial decisions. While we aim to provide valuable and accurate information, we make no guarantees regarding the completeness or accuracy of the content. Any reliance on the information provided is done at your own risk.